This
Okay, how's everybody doing?
doing good.
Good, thank you.
Okay, so let's pick up where we left off. So we were on chapter 4. And we had made our way sort of through, not quite, about partway through the dense connective tissue. Sound about right? So we left off, we were talking about the dense regular connective tissue. And so how basically this is laid down in sheets, oftentimes for structural rigor, because you have, say, for instance, things like tendons or ligaments that needs those basically kind of ropes, essentially, of connective tissue. So dense regular connective tissue, when you take a look at it, if you want to know what that looks like, it's almost mostly collagen. You can see there's very few cells in here. So you can see a couple of cells in there, but most of it here is connective tissue. It's collagen basically laid down in layers. And so this is usually about as structural as you get without turning yourself into cartilage or bone. And if you want to know what almost pure collagen is like, just grab onto your Achilles tendon. So that is pretty much almost pure collagen, which makes a lot of sense because you're putting a lot of weight on your legs, and that in particular is like a load-bearing tendon. And so you're kind of bearing the brunt of your weight on that tendon. So you got to have a lot of structure and toughness to that. Now, dense irregular is a little bit different, right? So dense irregular is still made out of collagen, still very collagenous, right? So you're basically looking at collagen fibers. Only in this case, basically what dense irregular is, this is kind of like more of like a structural loose filler. Remember we talked about areolar being a loose filling type of a tissue, like a loose filler. And that's kind of if you don't need a lot of tough structural toughness to it. And so you just need to sort of take up space, basically, kind of fill the gaps. And so you use areolar for that purpose. Well, this one you kind of do the same thing, only it's usually associated with tissues that have a little bit more mechanical stress to them. So like your skin, for instance, or things that are kind of getting beat up a little bit more, you need a little more toughness to it. And so you can use this as your loose filler to basically kind of toughen up that connective tissue. So this is oftentimes seen when you have a lot of mechanical stress. And so as a result, typically when we see it, like histologically, when we looked at it, we saw it as part of not just the dermis, but in other tissues as well. So when you get into organs and things like that, like connective tissues, especially in the digestive system, a lot of that is dense irregular because you got a lot of movement, motion going on in your digestive tract and the intestines and things like that. Things are constantly in motion. That's normally just before you like, you know, kind of are moving around and kind of squirming around and causing your intestines to kind of, you know, buckle and squiggle around. So you got a lot of mechanical stress associated with that. So you tend to see dense irregular. It's typical, the way you identify it is basically you've got these pink waves. So when you take a look at this tissue, and oftentimes you see other types of tissue embedded in it, like for instance, you see here this kind of what almost looks like a gland in that particular area. It looks like it's embedded in these sort of waves of pink swirls. That's the dense irregular connective tissue. And so it's kind of a dead giveaway when it has a pink swirly look to it. That's dense irregular. And so those are your two dense or fibrous connective tissues. Then when you take a look at dense regular elastic, the elastics as opposed to the collagenous, This is, you don't see this quite as often usually. And so what you end up seeing is essentially you see a lot of elastic. Now they're kind of pointing to elastic fibers here. That's kind of hard to see because it's not blown up, but there's like little elastic fibers that kind of run basically in this tissue. So you normally have this kind of collagenous network, but ultimately you have these kind of these elastic fibers. They're not really stained for elastic fibers in there, but that's kind of what this is. You have a lot of elastic fibers in there. Remember, we started off talking about your extracellular matrix has a combination of a couple things, right? So you have your ground substance in there, and you have your collagen fibers, which gives you that toughness, and that's kind of what the dense regular collagenous are doing. And then if you need a little more flexibility, you can add those elastin fibers in there to give you a little bit more flex in there, and that's kind of what these are. So you're basically taking this kind of dense irregular and dense regular tissue, but in this case, instead of loading it up with collagen, you're loading it up with elastic fibers, and that's giving you more of that flexibility. A good place to find that is in your vocal cords. Your vocal cords basically are kind of elastic tissue, and they're designed to kind of be a little malleable, right? So you kind of do with your vocal cords while you're singing or talking the kind of the same thing you do with your lips when you're whistling, right? So you kind of are cinching your lips down to kind of get a particular tone. And if you want to get a little bit more of a lower tone, you kind of open up the hole in your lips and that kind of drops a little bit. If you want to get higher tone, you kind of make that hole a little sharper, a little smaller, and that gives you a little higher pitch. You're kind of doing the same thing with your vocal cords. You're kind of constantly sort of teasing them, I guess, kind of bending them and sort of folding them around the air as it goes through your trachea and your larynx to get a particular sound to it. And that's kind of what we're doing when we're kind of manipulating our vocal cords to get particular sounds and things of that nature. So that's dense regular connective. Now, dense irregular connective is oftentimes kind of added into, you can see it looks like the same picture because you oftentimes see them in kind of the same place. And so in this particular case, what you have is not just collagenous, but also elastic in there as well. And so it's not uncommon to sort of see them in sort of the same places that you see them when you have dense irregular collagenous. Mostly because, especially with our skin, right? It's not just collagen. We also need a little bit of flex and recoil with our skin as well. So there's a lot of elastic material in there in addition to collagenous material. So it's not just one or the other. We oftentimes will see this elastic irregular connective tissue in arteries, right? Because arteries are constantly having to sort of flex. They have to sort of expand outwards with your increase in blood pressure. And then when the blood pressure passes and the pressure goes down, they have to be able to recoil and kind of adopt a regular shape. And so as a result, you have these elastic membranes in your arterial walls to allow you that kind of flex. It's kind of like one of those garden hoses that has a tendency to flex as the water comes through. And so you see a lot of elastic tissue in there as well. And so they come usually in the form of membranes. And so we usually refer to them as elastic membranes when we actually get to those particular sections in the textbook itself. So that's your connective tissue proper, so to speak. The next grouping is still connective tissue. I guess it's the not so proper connective tissue, I guess, right? So this is going to be more of the supportive stuff. Now, before we had was a lot of filler, right? Kind of a lot of sort of foundational stuff, loose fill, those sorts of things, just basic sort of foundational types of connective tissue with a couple more specialists in there, like tendons and things like that. But now we're looking more specifically. So it's not just general filler. We're now looking at tissues that are truly basically focused in on supporting and allowing structure to overlying tissues. And so the first of the supporting group is going to be cartilage. And so we talked already about a little bit about the cells associated with cartilage, right? So you have chondrocytes, which are the cartilage cells. They're basically going to be laying down the matrix. And so basically what happens is they lay the matrix around themselves. They kind of entomb themselves a little bit. And then they kind of create this hollowing, which is the lacuna. So this is basically a hollowing of the matrix within which the cell lives. So it kind of creates a little den for itself. And that's the lacuna. That's the same structure you see, not just for cartilage, but you also see that same kind of a pattern for bone as well, right? So we're going to take a look at this, the common sort of a thing. Now then, when you take a look at the matrix of cartilage, and how it differs from, say, the connective tissue proper or from bone even. When you take a look at it, you start off with the ground substance, right? So first of all, the ground substance of cartilage is typically a little firmer, so it's more of a tough consistency, a tougher consistency. But it typically will have a ground substance that has the hyaluronic acid complex together with your proteoglycans to create a mesh that will basically trap water. We talked a little bit about that already, kind of have cartilage in mind when we were talking about that basic structure. But unlike bone, this is a tissue that has a little bit of flex in it. So it has the ability to be sort of physically manipulated, like your nose, for instance, your nasal cartilage. You can kind of move your nose back and forth, and you're not like, it's not like staying in one side. It just sort of snaps back. So it's got a little bit of that sort of elastic spring back associated with it. And that's a part of its ground substance and that kind of quasi firm aspect of it. The important thing about cartilage, however, is that it's avascular. That basically means there is no blood supply and no nerve supply. And as a result, when you damage cartilage, it's slow in healing. Why? Because healing requires the delivery of materials and cells to do the healing that usually is borne by the blood vessels. And it also needs a nerve supply in order to sort of stimulate that healing as well. So it's all coordinated by the central nervous system. And so when you don't have that, it basically means you're going to be slow in actually healing yourself up. It's one of the reasons why cartilage is always a little on the difficult side, right? You break a bone, no problem whatsoever. You can always just, put it back together and bone will fix itself quite readily, quite nicely, as a matter of fact. But soft tissue injuries, generally speaking, we're usually talking about connective tissue injuries a lot of times, ligaments and things like that. You're skiing and you blow out your knee or something like that. That's usually what we're talking about, but it also encompasses cartilage as well. These things are slow to heal, and sometimes they're very difficult, and the damage is oftentimes long lasting, right? So for instance, when you have bad knees as you get older and you start to get arthritic, that's basically wear and tear on your articular cartilage. And you don't get that back, right? That's a one-way street. So once you start losing the cartilage in your knees, it's gone, right? You don't get that one back because they don't really heal themselves. They don't really come back and they don't heal like other tissues do. So they're really problematic. That's why it's always important to kind of take care of your joints in particular, especially for athletic folks, is because there's a lot of important hyaline cartilage in those joints. And we'll talk about that in chapter 9 a little further on in the semester. But those are really critical because a lot of times when you mess up a joint, you're usually screwing up one of two things. You're either messing up the cartilage that's associated with that joint, in which case it's a tough heal because it heals slowly, right? Or it's connective tissue, like a ligament or tendon or something of that nature. Both of those take time, and they're a difficult injury to get over. So around cartilage, you have what's called a perichondrium. So a peri means around. That's basically what that term means. Chondrium is referring to the cartilage. And so around the cartilage itself is dense irregular tissue. It's connective tissue that surrounds it. And in the perichondrium are fibroblasts. Our fibroblasts are the cells that basically lay down connective tissue. And so these particular fibroblasts of the perichondrium have the ability to differentiate into chondroblasts. Remember, chondroblast, a blast cell, is a cell that's laying down fresh matrix from the beginning. And so once you actually generate a chondroblast, then you're able to lay down new cartilage. Okay? But since you don't have a lot of vasculature supplying these cells, then you're kind of limited in what you can do. If you have massive cartilaginous injury or kind of destruction of the cartilage, it's a little difficult for your limited supply of fibroblasts to cover that much damage. And so if you have a little bit, they can probably cover it. They can differentiate into chondroblasts. They can lay down a little bit of cartilage, kind of keep you going in the right direction. But for the most part, depending on the nature of the injury, it's more difficult than most to come back from. unlike epithelial tissue, which is highly vascular and highly innervated. So it's very easy for epithelial tissue to repair itself, not so much for the connective tissues. There's three types of cartilage. You have hyaline cartilage, fibrocartilage, and you also have elastic cartilage. So these three. Now let's go ahead and take them in turn. Hyaline cartilage is probably the one that is the most common. For instance, if I were to ask you, point to an area of cartilage on your body, what would you point to? So I've got an ear, right? Our nose. Anybody go for the joints? So your knee, you're a knee person. Elbows, wrist, pretty much all the joints that we think of are by large, mostly hyaline cartilage. Most of what we point to is hyaline cartilage, except for the ear. We're going to hang on to the ear. So those of you guys who pointed the ear actually pointed to a non-hyaline cartilage source, but hyaline cartilage is probably the most common type in your body. And when you take a look at it, it essentially coats a particular type of joint called a synovial joint. A lot of your load-bearing joints are synovial joints, and they're essentially, the bones are covered with a layer of this hyaline cartilage. Think of it as sort of like a little shock absorption pad, but it's not a great one, right? So it's not like you can just have, naked cartilage and then expect your bones to just go against each other on that cartilage and expect it to feel good, right? Because when you have arthritis, people who have really bad knees, who are having a hard time taking a step without a lot of pain in their knees, oftentimes what they're experiencing is that cartilage on cartilage clapping together of their joints, because they've largely lost a lot of the other connective tissues in there that are supposed to spare those cartilages. But your tracheal cartilage is hyaline cartilage, right? So the tracheal rings in your trachea are little rings of hyaline cartilage. When you look at hyaline cartilage, it's kind of spread throughout everywhere, a lot of places, but this is kind of what it looks like. So you can see, first of all, the little cells, I'm going to change the weather. The little cells inside these little openings, the openings are the lacuna, and the little purple dots inside the lacuna are the nuclei of the cells themselves. Okay, so this is what you're seeing. All these little bubble-like structures are the lacuna, within which you have the chondrocytes just sort of hanging out. Now, the tissue itself, this area right in here, has this, oftentimes hyaline cartilage has this kind of very sort of glossy, kind of airbrushed look to it. And that's a pretty typical look to the matrix of hyaline cartilage. So that's the first type of cartilage. The second one is fibrocartilage. Fibrocartilage typically is white in nature. You'll still see that same organization. You'll see the lacuna with the chondrocyte in the middle of it, but then all of this fibrous, you can see actually all those like little waves and fibers, almost looks like insulation in a house. But these are all very strong and very tough. So fibrocartilage is a very tough type of cartilage. You're not interested in mobility with this type of cartilage. You're interested in shock absorption. So for instance, your intervertebral discs are basically rings of fibrocartilage that's designed to keep the stress of you walking, keep your vertebra from smashing on each other, which if that were the case, your bones would start to quickly wear down, and it would be incredibly painful. Anybody whose discs are kind of malfunctioning and they've got vertebra on vertebra clap, I mean, taking one step is very painful. And so it's not a good situation. The other type of fibrocartilage plug that you have is actually in between your pubic bones. So since we have our skeletons here, your pubic bones down here are very close to each other. And so you have a plug of fibrocartilage in between there to keep those two pubic bones from clapping together. If you didn't have that there, and every time you took a step, your pubic bones would hit each other, and it would be like, ooh, right? I mean, it would be like a lightning bolt in your hips. And so that's another main place that you're going to see it as well. Okay, now let's take a look at the elastic cartilage. This is for those of you who pointed to the ear. All right, so the elastic cartilage is probably the least common of, speaking of cartilages. Elastic cartilage is typically designed for flexibility. And so as a result, you use elastic cartilage when you want to create a structure that has sort of collapsibility, right? Your ear is a perfect example. Your ear has, first of all, kind of like a little quasi-rigid structure, right? It's not like it's just sort of flopping down like a little dog ear. It's got an actual rigid structure and it stays put. But you can still kind of crush it down and kind of fold it up and collapse it. And then when you let it go, it just goes right back to its original shape. That kind of elasticity is characteristics of elastic cartilage. Typically speaking, you use elastic cartilage on larger structures, right? So some of the other types of elastic tissues, like the connective tissues or elastic, typically are mostly reserved for smaller structures, things like blood vessels and stuff like that. This is a little bit of a bigger structure. You need a little bit more structural kind of backdrop to it. And so this kind of gives you that more kind of that tougher type of structure. And that kind of allows your ear to sort of stay open so you can actually catch sound waves. Okay. Now, first of all, notice that the three different types of cartilage kind of have an order to them, don't they? So you have the really, really flexible type of cartilage, elastic cartilage, when you need a lot of flexibility. You have the really, really tough one when you need just shock absorption, right, to protect yourself with. And then you have the one that's in the middle. It's kind of like a little bit of toughness. It's a little bit of elasticity. So you kind of have this kind of like this sort of splitting the difference between the two. And that's one of the reasons why hyaline cartilage is the most common. Okay, now let's take a look at the other supporting type of connective tissue, bone, right? So this is basically different than cartilage in the fact that bone is hard. So it's a hardened, calcified type of connective tissue, basically maintained by the osteocytes who lay down a mineralized matrix. Not mineralized first, but it becomes mineralized to create that hardness. And so the matrix here is designed to give you maximum strength and rigidity. And so you basically have load bearing, right? You have organ protection, ambulation, so your ability to move. You can protect your tissues, your brain, your organs, and things like that. And so typically in the extracellular matrix of bone, you have a couple of different types of things in there. First of all, you have the organic stuff. The organic stuff is our good old friend that we saw from before, collagen fibers. So you probably imagine that for something that's solid and supportive, that you're probably going to have these tough collagenous fibers around here somewhere. And that's exactly what you see. So you see these collagen fibers populating the ECM to give your matrix toughness. But if you just stop there, you wouldn't be any different than, say, a ligament or a tendon, right? So some of that dense regular connective tissue. So the question is, how is bone different? Well, bone is different because it's got another component to its extracellular matrix. It's got an inorganic part of it as well, not just organic. The inorganic part of it is composed of a couple of different things. First of all, calcium and phosphate, two very important minerals in your diet because of your bone growth. The two of those will combine to create another molecule called hydroxyapatite, which is this kind of calcium phosphate gamish molecule. And so this is basically what cures and what hardens the bone. So if you want good hard bones, you have to have calcium. If you want good hard bones, you have to have phosphate. Otherwise, you're not going to be able to harden your bony matrix. So generally speaking, the osteocytes, which themselves are also located in a lacuna, very similar to what we saw with chondrocytes, these guys are a little bit different because unlike cartilage, bone is actually very vascular. Matter of fact, if you break a bone, like you get a compound fracture, basically protrudes out of the skin, it's a bloody mess, not just because you lacerated a bunch of muscles and arteries and things like that. I mean, that's bad enough. But because the bone itself is loaded with arteries and veins and things of that nature. And so even if it were just a bone, it would still be pretty bloody. There's a lot of blood going through a bone. There's two different types of bone that we see. Spongy bone, the first type, and of course compact bone. And each of them has their role. So let's go ahead and take a look at spongy first. So spongy bone basically is kind of like the bone that you see oftentimes in the tips of large bones that kind of has this sort of spongy-like nooks and crannies. So that's kind of what it looks like. So it kind of looks like a sponge. So you have these like little ribs of bone with all these little holes and things like that in between them. And so when you take a look at them under a microscope, this is what it looks like. So here is these little rib-like structures here. These are what's called trabecula. And then in between them are these little open areas. So this is like a little open area here. And then you can see another trabeculum. We're looking at it in cross-section, head-on. And so you can kind of see you create these like little nooks and crannies throughout your bone. And so as a result, this ultimately allows you good structure, but it also allows you to be able to harbor a lot of cells in them so that you can actually do some cellular work. And in this case, this is kind of where your bone marrow is hanging out as well, is in this spongy bone. So it's kind of like this lattice work of bony matrix. Now, compact bone, notice we're looking at the same thing. This is the tip of the femur. You oftentimes see compact bone in basically the same, roughly the same area. So in this particular case, we're going to take a look at compact bone on the collar of the bone itself. You'll see this very dense, compact collar of bone on your femur. And so this is compact bone. Actually, its structure is a little bit different. So when you take a look at the structure of it, it basically has this classic structure we call an osteon. So this right here is a picture of an osteon. And in the osteon, you start off with your blood supply, right? So if you take a look at the central portion, you have your blood supply here. So that's basically a blood vessel that's carrying blood through the bony matrix. And then around the bony matrix, you're going to see these like little black circles. Those are little osteocytes that are inside their little lacuna, their little openings. And what they've done is they basically laid down concentric rings of what we call lamellae or bony tissue. And so it looks something like this. So here's your central canal. One osteon will lay down a first ring. So here's the little osteons here. And then you'll lay down a second ring. And then they kind of create their little lacuna. And then they'll lay down another ring, and so on and so forth, of bony matrix. So you start to get this kind of concentric ring structure. That's the osteon. But you notice there's a lot of lateral lines. It almost looks like there's a lot of stress fractures in it. These little stress fractures are basically the way that these cells actually get blood. So you'll see these like little lateral lines that basically all kind of end up going down to the central canal. And these little lines are like little channels. They're like little tunnels connecting the osteons to the central canal. So these are what's called canaliculi. Little small tubes or conduits that basically laterally connect the osteocyte to the blood supply. Doesn't really help us here, but okay. So that's one. That's kind of one piece of. So you have spongy, and then you have compact. Okay, and there's a reason for that. We'll talk more about that, especially when we get to the bone chapter, the bone physiology chapter, when we talk about some of the strategic decisions that we're making in terms of why do you put spongy bone where you put it, why do you put compact bone where you put it, things like that, right? To sort of tease that apart, especially when we get to the bone chapter. The next one is fluid connective tissue. And basically there's two different types of fluid connective. There's blood and lymph. Blood is the dominant one, right? So in this case, basically the fluid or the plasma, the blood is the matrix. Doesn't have any fibers, so there's no collagen in it normally, unless you're injured, right? Unless you've injured a blood vessel. And there's nothing like that. So typically, oftentimes, this matrix isn't formed by the cells that make up the blood. It's actually formed by other tissues, which is kind of a little bit different. So it's kind of a little bit of an outlier as the connective tissue group goes. But typically you have your plasma, which is your fluid matrix, and then within it you have dissolved red blood cells, white blood cells, and platelets that are dissolved in the actual fluid connective tissue itself, which is the reason why it's considered a type of connective tissue, because it's supporting the actual blood cells, the red blood cells and the white blood cells. The lymph, or the hematopoietic tissue, basically is, so there's a couple of different bifurcations that happens in most textbooks when you get to this particular section of the connective tissue. Blood is always there. Some textbooks will talk more about lymph, some will talk more about bone marrow. They're both important. Lymph is similar to blood. It's a fluid connective tissue. It's just mostly carrying white blood cells and things like that in your lymph system. In the other type, the hematopoietic tissues, that is to say, essentially blood cell production. That's what hematopoietic means. So these are tissues that are involved in that blood cell production. So typically blood is formed in the bone marrow. And so we're talking about the region of bone marrow that we have typically in the spongy tissue. So essentially you have red marrow in the spongy tissue, filling up all those nooks and crannies. And when you take a look at red marrow, you have basically the tissue that's surrounded by reticular fibers. And so this is where the white and the red blood cells are being made, is in this kind of red marrow region. The yellow region is basically adipose. It's yellow because there's adipose there. That's fat. But this is not a producer of red blood cells. So when you see a lion gnawing at a big old femur and he's trying to crack that femur open and he's trying to get the marrow out, the reason why he's trying to get the marrow out is because that yellow marrow is fat. It's fatty. And all animals, all mammals crave lipids. So he's eating that because for him, it's kind of like eating, you know, a donut, right? Or kind of like a bag of chips or something, right? That are good and greasy. That's kind of what it's like for the lion. That's why they're always after that marrow to kind of crack that open. So ultimately, as we get older, our marrow goes from red to yellow. So it converts over to fat. And so this is a pretty common sort of a thing. Some of our glands do the same thing, like our thymus gland, which when we're young is actively producing and developing T cells, lymphocytes. And as we become adults, it turns into fatty lobe on the heart because we don't need it anymore. So this is kind of like a summary of the connective tissue. So if you take a look at it, you can see you've got your connective tissue proper, where you have your loose connective tissue. So there's a shot of areolar, adipose, and reticular. So those are those top three. So that's these three right up here. And then you have your dense connective tissues. So you have your regular and collagenous and regular elastic. So they're side by side next to each other. So the left hand one is collagenous. That's your tendons and ligaments. The right hand one is elastic. So that's going to be the walls of the arteries and things of that nature. And so those are your dense connectives. And of course, your fluid connective tissue, which is your blood plasma bearing the cells of your blood. And then on the other side, you have your supporting cast. So you have your cartilages. In this case, this is elastic cartilage coming out of the ear, hyaline cartilage coming out of the trachea, fiber cartilage. They went for the pubic symphysis on this one. And then, of course, you have your compact bone, which they went for the femur on this one. So this kind of takes the same images we just saw in the chapter and basically plots them on the body in not all the regions, but in some of the regions that you would find these tissues. So those particular images are a nice piece, a nice addition in Sealy, because it kind of helps you to kind of coordinate some of the images you're seeing with some of the anatomical regions of the body and where you'd expect to see some of those tissues. Okay, so that's connective tissue. Any questions on connective tissue before we move on to the other two? It's enough to make your brain hurt, yes? A little bit? Yeah. You guys are like, yes, nice. So, yes, so we should have, like, headache medication in the lab, so students can manage their migraines as they go through A&P. Okay, let's talk about muscle tissue. So muscle, by the way, and nervous tissue are considerably shorter relative to the first two. And there's a reason for that, right? Because typically speaking, when you look at epithelial tissue, you don't really talk about epithelial tissue a lot, except for in passing, as you're talking about larger structures like the trachea and things like that. So you don't really get a chance to sort of just park it a little bit and just sort of unpack all the epithelial nooks and crannies of epithelial tissue. This is the only time we have a chance to do that. Same thing with connective tissue. Usually when you're looking at connective tissue, you're sort of diagnosing some other structure and how this connective tissue is creating support and foundation. And so you're kind of moving on from there. And so these are really this is the only chapter where you can get into that in any depth. Muscle and nervous have their own chapter, right? Because they've got their own systems. For epithelial and connective tissue, this is their system, right? They don't really have a system on their own. So they're kind of parts of other systems. So this is their chapter. This is where we talk about them. Okay. So a lot of these discussions in muscles and nervous system will be built on later on when we get to the muscle and nervous chapter. Okay, let's take a look at muscle tissue and what it does. First of all, muscle tissue is the contractile tissue. So its job is to contract. That's what it does for a living. So it contracts, or it shortens with force. And so it allows us to basically move our body. And also, if you're the heart, you basically pump blood. Now, there's three different types of muscle that you're going to see. The first one is skeletal. Matter of fact, that's probably the majority of what you guys would point to. If I asked you guys to point to a muscle on your body, almost all of you would point to a skeletal muscle, mostly because the other two muscles are deep inside your body. You only find your cardiac muscle, that's your heart, and that's the only place you find that. And smooth muscle is typically associated with your organs. So unless you're pretty adept at sort of digging around and sort of saying, I want to point to my intestines, chances are you're pointing to a skeletal muscle. Okay. Now, skeletal muscles are important because they have a couple of features associated with them. So number one is their attachments, right? So basically they're attached to the skeleton. And so in points that we call origins and insertions. So these are basically attachment points on the skeleton. When we get to muscles, oftentimes it helps to be able to understand the nature of how muscles are attached to the skeleton in terms of its origins and insertions, because sometimes it helps us to be able to identify the muscle, because many muscles are named after their origins and their insertions. Like a good example is the brachioradialis, right? So the brachioradialis, its origin is going to be on the brachium or on the humerus. The insertion is going to be on the radius, right? So that's radialis. That's basically the insertion is the bone that moves. The origin is the stationary point. It's like your reference point, okay? So you always have a stationary point and you have a moving point. That's how your muscles are lined up, an origin insertion. Otherwise, what's going to happen is if you don't have an anchor to that, what's going to happen is you're basically, both points are just going to move randomly, right? You don't know who's going to be moving, who the reference point is and who the moving point is. It's like if I want to move my arm, instead of it moving like this, brachioradialis, what's going to happen is it's going to be like, right? Both attachment points are going to move. So I'm going to move my arm and my radius at the same time. And so it's going to basically kind of collapse together. And that's going to be kind of, well, a little not helpful, right? So what I want is I want basically smooth movement. I want one to stay put and I want the other one to move relative to that so I can get more fine-tuned control. So those are important. You can also attach, however, and insert on connective tissue, right? So for instance, your supercilious muscles, which are your eyebrows, clearly they're going to be originated on the superior ridge of your skull, right? That's basically its reference point. And then the insertion, the moving part, is going to be to the connective tissue underneath your eyebrows, so you can kind of move your eyebrows around, right? So the origin stays put on your skull, but when the muscle moves around, it can move your eyebrows. That gives a spatial expression, so you can connect to connective tissue as well. And then the other thing is also they are striated. That means they're striped like a candy cane, and they're also voluntary. So you get to choose when and where and how to move your skeletal muscles. It's the part of your skeletal system or your muscular system that you have control over. Now, the cardiac is a little bit different, right? Because this is only found in the heart. It is also striated, but it is not voluntary. It's involuntary, which is a good thing, by the way, right? Because the last thing you want to have to do is constantly think about making your heart beat, right? That would create a lot of work for you to basically say, okay, heart beat, 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 right? I mean, every time you had to think about it, basically you would be not able to get anything else done. Or when you did think about something else, guess what happened? You'd forget to tell your heart to beat, and then you'd be like, right? You just basically drop dead. So it's involuntary because it's like, listen, this one's too important for you to think about. No, nothing against your thinking ability, right? But you don't want to think about this one. So we're going to put this one on autopilot, and we're going to let it do its thing. Okay. And so that's basically how cardiac muscle works. The last one is smooth muscle. And so basically smooth muscle is associated with your organs. So tubular structures, for instance, your blood vessels, your intestines, and so forth. They're also non-striated. They don't have a striping system, and they are also involuntary. Because the last thing you want to have to do is also think about how the food is moving through your digestive system, right? If you had to think about that one, think about this. There'd be a lot of things to think about, wouldn't it? You have to think about your heart beating. You have to think about moving your food from your stomach to your small intestines. And then when it's ready to go from your duodenum to your jejunum, you got to move it then, right? You could be like, okay, intestines move, but wait, heart, keep going, right? And so you have all these things to think about. So you put all these things, these visceral activities on autopilot. And so they're involuntary. So really the only thing you have control over is skeletal muscle to any degree. So this is kind of what skeletal muscle looks like. This is very classic kind of a look skeletal muscle. You can see they're long and cylindrical. And they oftentimes will be multinucleate. So they'll have many nuclei in them. So for instance, here's one nucleus, here's another nucleus here. And so they also happen to be striated or striped. So if you take a close look at this image, I'm going to blow it up. You can see that kind of candy cane look of those stripings. Those stripings we'll talk a little bit about when we get to the muscle chapter and we take a look at the structure of skeletal muscle. Those are important, especially when it comes to understanding and studying the mechanism of muscle contraction. These become very important, these striations. And so you can see they're basically these little striped cylinders with all these stripes. And they're very long. And so they're very kind of classic, very easy to identify. Cardiac muscle is a little bit different. You can still see, and I got to blow this up a little bit. So you can still see kind of has a little bit, the striping is not as significant. The striations are a little fainter. If you kind of look at it closely, kind of squint, you can see they're still striations. So it's still striated. But they typically will have one nucleus. They're striated and they're interconnected. And they have intercalated discs. That's kind of a very unique feature of cardiac muscle cells is the intercalated disc. So if you were to take cardiac muscle and kind of pull it apart a little bit, what would happen is you kind of get this sort of net-like structure. They would kind of be interconnected. And so you can see the interconnections between these cells. So you can see how basically one cell here is basically interconnected to these other cells. And so you can see how it's more like a network of cells. So this is the interconnectedness. They also have what's called intercalated discs. If you take a close look, you'll see that there's these little faint lines, these dark purple lines periodically throughout the tissue. Those are intercalated discs. What these guys are is basically they're gap junctions. And these gap junctions allow these cardiac muscle cells to communicate almost like unanimously. So like, for instance, when one cardiomyocyte hears a contraction signal, they all hear it. Why? Because that signal rifles through those gap junctions and pretty much everybody hears the same message in unison. This allows the cardiac muscle cells to be able to contract at the same time, which is critical for the normal function of the heart. Unlike other muscles, heart muscle has to contract all at once, because the idea here is, instead of holding a load, which like your skeletal muscles are trying to do, what you're trying to do with the cardiac muscle cells is basically get one good, strong, powerful pump, and then shoot that blood out of the heart and then to the rest of your body. The only way you can do that is that everybody contracts at the same time. And so the only way you can contract at the same time is if we all hear the message at the same time, right? Like, for instance, if I wanted you guys all to jump, then we would have to all hear that instruction at the same time, right? So on the count of 3, jump, 1, 2, 3, and we all jump at the same time. That's because we all heard the instruction at the same time. That's what these gap junctions do. Okay. Smooth muscle then looks like a bunch of gummy worms kind of sliding across each other. Looks like a handful of worms. And so you can see they're kind of more spindle shaped in nature. They have typically one nucleus per cell. And they're not striated. So they have a different type of a contraction mechanism, but they're important, right? Because basically these guys are the ones that are responsible for all the involuntary movements of all of your organs, right? For instance, the musculature of your intestines, what actually allows your intestines to move from one place to another, from your stomach to your duodenum to your jejunum to your ileum, is smooth muscle that lines your intestinal tube, basically. It's also smooth muscle that you see in arterial walls. That muscular layer in an artery is all smooth muscle. That's what allows your arteries to constrict and to dilate. And so these guys are very important. For our purposes, it's the culprit behind goosebumps. Right? So whenever you get goosebumps, you actually have a little bit of smooth muscle called the erector pili muscle in your skin. It's attached to your hair follicle. What will happen is, under the proper neural stimulation, sometimes when you're cold, sometimes when you are fearful, when you feel fear, it'll contract in sort of a flight or fight sort of mechanism, and it'll cause your hair to stand on end and your skin to raise just right above that erector pili muscle, causing a goosebump. Okay. And so this is kind of where we get that sort of whole phenomenon that most mammals get, actually, where you have the hair stand on the back of your neck, right? You ever walked into a room and your hair's kind of stood up on the back of your neck? No, you guys are chill. I'm the only one who freaks out like that, right? We've all done that, right? Because there's like something there that you don't like, right? You've kind of gone into a room and you're like, don't know what it is exactly, but there's something that's just like threatening. And I can actually feel the chill. I can feel like the goosebumps. There's a reason why that entire book series is called Goosebumps, right? Because goosebumps is not just temperature, it's also fight or flight. And the same thing's happening with that. What's happening with your hair when it stands up on the back of your neck is the same thing that's happening with the dog. What happens when a dog feels threatened? What do? They don't even know they're doing it. Yeah, like when you look at them, they're getting all like, the first thing they do is they get all blustery and they're like, right? They're kind of like making themselves all sound like vicious, even though you know them and you're like, whatever, right? But then if you take a look at them, you can see right between their shoulders and their neck, you see this big old poof of fur standing up, right? And then if you kind of go down on the rump, you see another little poof of fur standing up. So what are they doing? Yeah, they're doing what all mammals do. They're trying to look intimidating. They're trying to look bigger than they are. So it's kind of like, when two guys get in a bar and what do they start doing? They start doing the whole bird chest thing. They're all like, they're all kind of doing this thing, getting the chest out there. They're basically dogs, right? They're mammals. And that's kind of what they're doing. They're kind of like trying to make themselves all look bigger. When if you actually listen carefully and just sort of pay attention to what they're doing, it's like, yeah, you may be puffing out, but you really don't want this, do you? You're kind of bluffing. aren't you? I can see it because I can see you sweating beads of sweat. You're actually hoping that this works. You're not quite sure what's going to happen if it doesn't. Are you? Right. That's why. I tend not to get in very many fights, mostly because I know how to avoid them. It's amazing, actually, how few fights you can get into if you actually know what the other person is doing before they actually know what they're doing. But that's kind of what happens, right? We do the same thing. We're mammals. We get all big furred. Same thing happens to us, right? And that's what's happening. So it's kind of a mammal thing when we kind of get that fur standing up on the back of our neck. That's the reason why it's a fight or flight sort of a thing, right? We're trying to intimidate the enemy and hoping that they'll kind of back down. If you've ever watched two males in nature, animals, that's how their fight starts, right? Their fight always starts with posturing, right? They're always kind of like, trying to size each other up, and they're trying to like, well, I've got a bigger rack of horns than you do, right? And they're trying to like, so it's like, yeah, you do. So you go ahead and do whatever you want. I'll just go over here because I'm clearly the little rack guy, right? So that's kind of what they're trying to do, is kind of settle the matter before anything happens, and then the last thing they try to do. And that's kind of a typical mammal thing, and we're no different. So that's muscle. We'll come back to that when we get to the muscle chapter, but now let's take a look at nervous tissue, right? Nervous tissue is a little bit different because nervous tissue is the conductive tissue. So there's a couple of components to nervous tissue. And so when you take a look at nervous tissue, you have the neurons, number one, of course, right? These guys are the ones that have the ability to produce these electrical signals called action potentials, which we'll talk a lot about in the neurophysiology chapter. And in the neurons, you have a couple of major parts. So you have the cell body, which is the main body, the nucleus. You have the axons, which are the long trajectories that basically lead away from the cell body. So this is a cell process that conducts these impulses away from the cell body, oftentimes on their way to connect and to communicate with a target cell. And then you have the dendrites, which are basically more cell processes, but this is your reception. So you're receiving impulses from other places, messages, if you will, coming into you. And then what happens is you sort through all those messages in your cell body. You make some sort of a decision about what kind of a response you want to send out from there. And then that goes out of your axon to your target cell. Now, you have a couple of different ways that you can classify neurons. First of all, they can either be multipolar, basically have multiple different processes attached to them. They can be bipolar, where they have two main processes, one coming in and one going out. And you can have what's called pseudo-unipolar, which kind of looks like it only has one to it, but it actually has two. And so those are the neurons. We'll talk more about that in chapter 12. And then the other major group of cells that we see in nervous tissue are the glial cells, are the support cells. And so in the brain spinal cord, you basically have a group of cells that all do sorts of different jobs, but it's kind of the entourage, essentially, of the neurons, right? Every famous person has a posse, right? Or an entourage. So usually these people are others that basically take care of you, right? They're your assistants who take care of your schedule, or if you're really famous, and you're your bodyguards or whatever, right? So you kind of have these people that sort of have these various functions around you, but they're all designed to support you, because after all, you're the star, right? And so you get to be supported that way. That's what the glial cells are doing. So they're basically there to nourish, protect, and to cover or insulate the neurons. So this is kind of what it looks like. So here is a classic multipolar neuron, like a motor neuron. And so you can see the dendrites, basically, which are all coming in from other neurons typically, as they communicate with this neuron, different types of messages. The cell body, which is this large part right here, is going to be where the messages are going to be sorted through. And then the final communication, what is your cell body wants to do about that, is going to be sent out through the axon to your target cell. If it's a motor neuron, that target cell is typically a muscle. And this is kind of what it looks like. So it looks very clear. You can see this very star-shaped, classic star-shaped cell structure. Classic motor neuron looks like. So there's your star-shaped cell body. These are the dendrites coming in. And typically the one coming out is usually the axon. Maybe this one, but more likely this one because you can see it's a little thicker right there. So that's probably the axon. Oh, this is a pretty good sized dendrite coming in there. And so these are an example of a multipolar. And then the pseudo unipolar is so called because when you take a look at it, you can see it has a slightly different construction. So here's your cell body right here. Typically, it's going to be covered in these glial cells, kind of creating almost like a little covering for it. And then you'll see that it has a little branch coming out. So these are like branches of the axon. So here's the axon. Then what happens is it splits or bifurcates and it goes in two different directions. So it basically is the axon. It just sort of divides up into two different directions. Okay, so it goes two different places. And so that's basically what you're seeing here. You're seeing kind of the cross section of these cells themselves. So that's what they've done. They've kind of taken a cross section and then showed you the end-on view of that, of a pseudo unipolar. Okay. So membranes. So how do we put these tissues together in membranes? You have a couple of major types of membranes in your system. You have basically what's called mucous membranes. And mucous membranes are epithelial. You have serous membranes and you have synovial membranes. So a mucous membrane, generally speaking, will almost always line a region of the body has access to the outside world. Like, for instance, your nasal passages are lined with mucous membranes. Your respiratory system has a mucus type of a covering to it, right? So these guys have one role. Their job is to secrete mucus. And so generally the way you secrete mucus is the same way you secrete mucus. It's with goblet cells. And so generally speaking, you will have these goblet cells, which are the mucus producing cells. And their job will be to essentially make this mucousy secretion. So here's your big drop of mucus. And so these goblet cells will basically secrete this mucus on the outside surface, covering the epithelial cells. So generally speaking, you'll have your cells tethered to a basement membrane. And then on top of that, or underneath that basement membrane, will be a connective tissue layer, obviously sometimes called the lamina propria. So this is like a connective tissue substrate that's below the basement membrane. So it kind of gives you a little bit more structural support. That's we see that oftentimes in the digestive system. So basically, mucous membranes line those places that are in contact with the outside world. Serous membranes are a little bit different. Serous membranes are a line of simple squamous epithelium called mesothelium or endothelium that are attached to a membrane, and then sometimes a thin layer of loose connective tissue, oftentimes areolar. So you see something like this. There's your flat squamous cells, our basement membrane. So that means it's simple. And then generally speaking, underneath here is going to be a layer of areolar. But it's pretty thin in nature. And so what this is doing is it's basically lining two things. It's lining the cavities that are opened to that are not open to the exterior. They're internal. And then there's another line that lines the organ itself, right? So their serous membranes has a basic construction to them. So basically you have what's called the visceral membrane or the visceral liner. Then you typically will have some sort of a space or a cavity, and you have what's called parietal membrane. And that's a common pattern that you see throughout the body. For instance, the kinds of cavities they're going to cover are like the pericardial cavity, where you have a liner of parietal pericardium covering the pericardial cavity that's in the lower portion of the thoracic cavity, called the middle portion, which is the lower mediastinum. Okay. Then you have a pericardial gap, right? And then you have the visceral pericardium, which is the layer that lays right on top of the heart itself. For the lungs, it's the pleural system. So you have the pleural cavity, which is the two lung cavities in the thoracic cavity where your lungs reside. There is a parietal layer that lines the cavity wall like wallpaper. Then there's a parietal, parietal. There's a pleural cavity. That's the little space between the cavity wall and your lung itself. And then there's a visceral pleura, which is the layer of serous membrane that rests on top of the lung tissue itself. Okay. And the same thing is also true for the peritoneum. The peritoneum is your abdominal cavity. So the parietal peritoneum is lining the wall of your abdominal cavity like wallpaper. And then you have the cavity space. And there's a lot of space in your abdominal cavity. And then resting on top of the organs itself is that thin line of the visceral peritoneum, which in the peritoneal, it actually has a lot of different folds and things like that. And then the synovial membrane is associated with movable joints. And this produces fluid like hyaluronic acid, ground substance fluid, which is lubricant, it's slippery, into your joint spaces to allow for freedom of movement and reduction of friction. And so this is kind of what it looks like. So you have your mucous membranes, for instance, covering your respiratory and digestive system, serous membranes covering your pleural, peritoneal, and pericardial, and your synovial membranes that are encapsulating your joints and providing kind of a smooth lubricant so that you have good, smooth, fluid joint movement. Now, what happens when we run into tissue damage and inflammation? So basically, whenever you get into tissue damage and inflammation, you get into the inflammatory response, which basically means you mobilize your immune defense. And then ultimately, the point here is to destroy infection, to remove damaged cells and things like that. So you're kind of hiring the crew to kind of come in and clean up the mess, clean up the debris, and then kind of get yourself ready for wound healing, because you've damaged a lot of tissues and now you got to repair that tissue. Typically, the hallmarks of inflammatory response are redness, heat, swelling, and pain, right? So redness because it's more vascular. So you're getting more blood flow there to deliver all of these different cells that need to repair and clean up the site of damage. Heat because blood is hot. So the more vascular you are, the more hot you're going to be as well. Swelling because blood is fluid and you're basically filling your tissues with more fluid. So you're going to get swelling there, and of course pain because it hurts, right? So, so that's kind of what it looks like when you take a look at the inflammatory response. So basically in this case, you kind of get a splinter. Notice you kind of cut through your epidermis into the connective tissue. You bring in all sorts of bacteria. So that's all these little green guys in there. So you see all this bacteria in there, and you're also doing a lot of damage. You're hemorrhaging, so you got lots of red blood cells spewing all over the place where they shouldn't be, and then that's going to be causing things like redness and bleeding and bruise creation, things of that nature. So that's the first step. Chemical mediators at this point are typically going to be released so that you can coordinate your inflammatory response. And then you're going to be bringing your immune cells to the site of infection to do battle with the bacteria. And so that's what all these little blue cells are. Those are neutrophils that are basically actively coming in to do an attack on these guys. And then once you get that under control, then you're basically going to go through your wound repair. So ultimately, what's going to happen is you're going to plug that hole, oftentimes, first of all, with a blood clot. And so because blood is a type of connective tissue, it's probably the structurally weakest of the blood tissues, but it'll work in a pinch, right, to kind of get things to stop. And that's kind of where it starts. And so once you actually fill that in with blood, that's going to be enough to stop that. And then the thing that you want to do is you want to kind of start moving into clot formation. And then so basically you're going to move into kind of clot formation. And this is actually a little further down the road. We want to go here next. So once you've kind of filled that in, it kind of turns into the sort of dried blood, scabby looking structure. That's basically your scab. Underneath your scab, what's happening is your scab is retracting, it's drying, and it's pulling everything together. So it makes it easier to heal. And then all of a sudden, what's going to happen is you have your skin, your epidermis right here, with all your fibroblasts basically surrounding the tissue while your white blood cells are doing battle, killing off all the pathogens. And so you start to reconstitute your epidermis. You start to rebuild your epidermis until you get a full surrounding. So notice what's going to happen is your epidermis will surround it completely, and it'll start to repair upward. So as it's laying down new epidermis underneath the scab, that skin is slowly starting to mature and is starting to reconstitute itself. So it's basically starting to re-establish that layer, that thick epidermal layer. Underneath in the dermis, you're going to have a lot of what's called granulation tissue. This is where your fibroblasts are laying down connective tissue just randomly. So you're just putting stuff down there just to hold it all together, right? You're not really worried about organization or geometry at this point. You're just kind of putting it all in there just to kind of hold it all together. You just got to put some connective tissue in there. And then so that gives this upper level of tissue enough support so that it can continue to reheal. Because remember, the epidermis is mostly epithelial. The dermis, which is the part that we're dealing with here in the granulation tissue, is mostly connective tissue. That's the reason why the fibroblasts are laying down that connective tissue, to give you just a little bit of structure so that those upper level epidermal cells can have enough structure to be able to reconstitute themselves. They need a foundation to stand on, and that's what this granulation tissue is doing for them. And then eventually what's going to happen is as your fibroblasts kind of continue with laying down this connective tissue underneath, you sometimes can see a little bit of a raising in the form of a scar. So scars are actually dense, irregular connective tissue that's been laid down during wound healing, but it's irregular. So it doesn't look like the surrounding tissue. So it creates an irregularity in the skin. Okay, and that's basically what a scar is. So when you take a look at how this works with cancers, typically when you take a look at different types of cancers, most of them are epithelial in nature. Why? Because these are oftentimes dividing, right? And so it's the dividing cells that then become vulnerable to kind of a cancerous presentation. And so oftentimes we'll get carcinomas, which are cancers of epithelial tissue. And so that's pretty much lung, breast, so any kind of epithelial tissue, whether it's secretory, whether it's a liner, colon, prostate, skin cancers, things of that nature. And then you have adenocarcinomas, which are typically glandular in nature. And so those are the two different. So if you have like a carcinoma, that's typically more of like the liners, typically we're looking at, and then the adenocarcinomas are typically the glandular. And then sarcomas typically are connective and muscular for the most part, right? So these so-called mesodermal tissues, connective tissue and muscular tissue, which are a little rare because they're not, the reason why is because they're not actively dividing. So they're less likely to occur and they're less common. So aging, well, pretty much in a nutshell, everything gets less efficient with age. As we get older, things get less efficient. For instance, cells divide more slowly, so we have cell replacement less slowly. That means that we don't heal as readily because those cells are not dividing as quickly. Collagen fibers become more irregular in structure. And so they don't work as well. That's the reason why our joints break down as we get older, because we have tendon issues, ligament issues, things like that. Our connective tissue just starts to break down. Our elastic fibers become less elastic. And so we have, and this basically is across the body. We're not just talking about skin. We're not just talking about joints. The really bad thing about aging is this affects all of that elastic tissue in arterial walls. So your arteries become more stenotic. That is to say they're less elastic, which is a bad thing, right? You get more plaquing, which is reduced blood supply, wrinkling of the skin because you have the breakdown of connective tissue in the dermis. And of course, more likely for bones to break because they are not maintaining the compact bone structure. So the osteoclasts, which tear down bony matrix, start to win as you get older, and they break more bone down than the osteoblasts can put down to replace. Okay. And so these are all the things that happen in aging. So it's not necessarily what you look like on the outside that gets you. It's what your body is looking like on the inside that gets you, right? And this is one of the kind of the tragic things about cosmetic stuff, right? Is like you try to make yourself look great on the outside, but that's like the least important of everything that's going on in your body. The least important thing that's happening in your body is not how you look, it's how things are working. And so you may look great on the outside, but your arterial walls are still becoming less elastic as you get older. And so that's, you can't stop that one. Does that make sense? And so just remember that next time you go and you consider smoothing out those wrinkles. Right. Right. So not that you guys have to worry about that. It's, you guys don't have to consider that for a while. You guys are well, that's well in your future, right? Not your present. So, but anyway, that's that. That's the end of chapter 4. So we're going to start off with chapter 6 next time.